Why don't you keep this? I'll just talk from here. You don't need the bigger screen.
No.
Do you need the bigger screen?
Yeah, because this is how it's
That's how
recorded.
it's going to be called. Okay.
Yeah.
It's recording the whole thing. Okay.
Okay.
Start.
Mm-hmm.
Hello, everyone. Welcome to the webcast on hyponatremia, new guideline-directed treatment options. My name is Chris Vijay. I'm a clinical professor of medicine, a practicing cardiologist in Scottsdale, vice president of director of heart failure program. Thank you for your presence. Today, we'll talk about hyponatremia. Hyponatremia is defined as sodium less than 135 millimoles per liter. Hyponatremia is the most common electrolyte and fluid-based abnormality encountered in clinical practice. It can lead to symptoms that are very mild to life-threatening. It is associated with increased mortality and morbidity, increased length of stay, and increased prevalence of falls, increased neurocognitive dysfunction, in turn leading to a significant economic burden for the healthcare community. In spite of the above comorbid conditions, management remains incomplete with increased risk-benefit ratio with currently available therapeutic options. In the next few slides, we will review the demographics and the burden of disease, followed by causes of hyponatremia and some of the new treatment strategies with oral urea. So in this slide, as you see, the prevalence of hyponatremia is well depicted. In a large 120,000 patient study, they found up to 28% of hospitalized patients may have hyponatremia. With about 3.2 to 6.1 million hospitalizations annually, this translates to a significant financial burden of about $3.6 billion that is attributable to hyponatremia. In this slide, the classification of hyponatremia is depicted. The hyponatremia essentially can be classified to euvolemic hyponatremia, hypervolemic hyponatremia, and hypovolemic hyponatremia. For our discussion, we're going to restrict this to euvolemic and hypervolemic hyponatremia. Because of SIADH, which is also called syndrome of inappropriate antidiuretic hormone secretion, hypothyroidism, poor osmolar intake, the tea and toast diet, hyponatremia can be due to volume depletion from many different causes. In the next slide, the euvolemic hyponatremia due to SIADH is depicted, and some of the causes for SIADH include neurological related, such as infection, trauma, subarachnoid hemorrhage, subdural hematoma, hydrocephalus, and multiple sclerosis. Some of the cancers can cause hyponatremia that leads secondary to SIADH, can be from carcinoma, from lymphoma, and sarcomas. The pulmonary causes for SIADH includes infection, such as tuberculosis and pneumonia, which is very common. Also, asthma can give rise to SIADH. Cystic fibrosis is also related to SIADH. What are some of the drugs that can lead to SIADH? Well, as you know, the SSRIs are very common, antipsychotics, narcotics, cyclophosphamide, some quinolone antibiotics, as well as the first-generation sulfonylurea. What about stress? The pain and vomiting and post-surgical situations can all lead to SIADH as well. Sarcoidosis can lead to SIADH, and even AIDS is related to SIADH. In the next slide, the sequelae of hyponatremia is depicted. Even small declines in serum sodium levels are associated with increased mortality risk. Even small declines in serum sodium are associated with significant neurocognitive deficits. Falls in the elderly can be very common with hyponatremia. Increased hospital length of stay, reduced bone mineral density, increased risk of pathological fractures, exclusive of falls, and increased cost of care are some of the other sequelae of hyponatremia. In the next slide, we have depictions of the relationship between hyponatremia and mortality. There are about 9 studies over here, as you know, that the mortality varies anywhere from about 9% all the way to 51% mortality. And many of them are associated with even a sodium level as high as 134 and even as low as 120. So clearly, the mortality and hyponatremia are significantly related, and we ought to have some treatment strategies that we can impact both mortality and morbidity. This next slide talks about hyponatremia and mortality. The increased risk of death from hyponatremia is seen in Copenhagen Holter study, where the hazard ratio was noted between 1.21 to 2.39 from a plasma sodium which was ranging between 135 to 137, even in patients who were not using diuretics. In another study called Gancum-Kegney, they found that the prevalence of hyponatremia was 6.3%. This is also the Dallas Heart Study. About 3,551 patients were enrolled in this study, and they found a hazard ratio of 1.75 for mortality with hyponatremia as an independent risk factor. In the Rotterdam study, where they enrolled more than 5,200 subjects, it showed a prevalence of hyponatremia of 7.7% in an elderly population. The hazard ratio for mortality in this study was 1.21. In the next slide, falls and neurocognitive deficits due to hyponatremia is depicted. The couple of studies, as you see in this slide, include that of Ghosh et al. And Bunn et al. The one that Ghosh did matched about 129 geriatric hyponatremic patients, the same number of geriatric normonatremic patients. They administered the comprehensive geriatric assessment tool, and they found that in multivariate analysis, the patients with mild hyponatremia had significantly worse outcomes in the cognitive and functional testing. In another study where psychiatric patients were investigated, they found that hyponatremia was associated with an increased fall risk with an odds ratio of 4.38. That means a more than 4-fold increase in risk of falls due to hyponatremia. Let's look at the next slide. Falls and neurocognitive deficits was also studied by Rennie Boog, where they looked at about 122 patients in the intervention arm who had hyponatremia, and then 244 patients in the matched control arm. And they found that hyponatremia was associated over a 3-year period with a prevalence of 21.3% of falls versus 5.3% of falls in normonatremic controls. Correction of hyponatremia improved attention deficit as well, as measured by auditory and visual stimuli. The next slide, another study by Gunathilake, who evaluated cognitive function in asymptomatic community-dwelling individuals in what is called the Hunter Community Study. They found that the cognitive function was higher in individuals with a plasma sodium of 135 MEq per liter compared to those with 130 MEq per liter. After controlling for demographic and diuretic use, hyponatremia was associated with a 32% increase in the fall risk. Let's look at some of the treatment options. We know now that the intravenous hypertonic saline is mainly used in the acute emergent settings. You don't really use the hypertonic saline if there is not an emergent situation. Seawater restriction is another treatment strategy. It may be effective, but limited by patient compliance. Demiclocycline is another option that's available. However, FDA has not approved this for hyponatremia. Demiclocycline carries a risk of nephrotoxicity. It's a tetracycline antibiotic, and inappropriate use in the absence of infection has a potential to build antibiotic resistance. It can also alter the gut biome. Another option that we all have available for us is the Vaptans. However, these Vaptans, such as Conivaptan or Tolvaptan, they all need hospitalization. The long-term use is not proved to be safe. there is a suggestion of hepatotoxicity. These agents are indeed very expensive. Another agent that is available for use for hyponatremia includes lithium. However, lithium is nephrotoxic and truly not recommended for this condition. Eliminating offending agents like psychiatric medications can also hopefully take care of the hyponatremia in some situations. However, it is indeed difficult at times because of lack of suitable alternatives available for some of these psychiatric populations. Urea has been recommended, but it's not been available for routine clinical use in the past, primarily because of the problem with palatability of raw urea. In the next slide, the treatment options of hyponatremia is depicted in a tabular format so that you can look at all the advantages and disadvantages of some of the treatment settings. As you see over here, the free water restriction in the setting of inpatient and outpatient setting in acute and chronic setting can be inexpensive and effective, but difficult to adhere to due to the unpredictability of the outcomes. Hypertonic saline, as we discussed, demiclocycline is not FDA approved, talked about Vaptans, and then finally urea, which is considered as GRAS, which stands for Generally Recognized as Safe designation by FDA, is also another option that we'll be discussing a little bit more in detail in the next few slides. The next slide tells us about the guideline recommended for treatment of hyponatremia utilizing urea. In the latest guidelines in 2014, they recommended use of urea over demiclocycline. Several major hyponatremic guidelines have recommended urea for use, primarily because of its safety and the efficacy. It is indeed well tolerated, but if it is in the raw form, it is not very palatable. And that's why there is an opportunity, as we will discuss in the next few slides, about utilizing urea in a more palatable form. Urea has an aquaretic effect. It is not associated with any electrolyte imbalance. No electrolyte depletion has been noted with the use of urea. There is no concern for nephrotoxicity. There is no concern for hepatotoxicity. It can be used in inpatient as well as in outpatient setting, in the ambulatory and critical care setting, as well as in the ICU setting. As mentioned earlier, urea is rated as GRAS by the FDA. So, what is the mechanism of action? Well, urea works in many different ways. The primary way that urea works is truly by inducing osmotic diuresis and decreasing free water reabsorption. This will allow for increased excretion of free water, which will then concentrate your serum sodium levels and increase it to a normal level. So these are all the primary mechanisms of action of urea. There are a few other mechanisms which is hypothesized. We will not go into the details of that at this time. So what are some of the clinical practice guidelines recommended for hyponatremia utilizing urea? European Renal Association, European Society of Endocrinology, European Society of Intensive Care Medicine, they all have recommended utilizing urea in patients with syndrome of inappropriate antidiuretic hormone. In moderate or profound hyponatremia, they suggest the following can be considered: equal second-line treatment, increasing the solid intake with 0.25 to 0.5 grams per kilogram per day of urea intake, or a combination of low-dose diuretic, loop diuretics and oral sodium chloride. So as you see over here in 7.4.3.3, it clearly demonstrates some of the agents that they are recommending against utilization in subjects with hyponatremia. So according to some of these guidelines, urea is taking a prominent role in the treatment of hyponatremia. What about UpToDate? Well, UpToDate also is recommending on the use of urea in subjects with hyponatremia, be it euvolemic or be it hypervolemic. Another way to increase urinary solute excretion and enhance the water excretion in patients with SIADH is administration of urea per up to date. It's usually at a dose of 30 grams per day. This regimen is reported to be generally well tolerated and has been used chronically in ambulatory patients. So what about the relevant clinical data utilizing urea in hyponatremia? As you see over here, a few of these studies are depicted. Urea for the long-term treatment of SIADH by DECO has been shown to impact the sodium levels favorably in multiple patient studies. As you see, no major side effects are noted even after treatment periods up to 270 days. More clinical data is available as well by Kusament, published at AJN. The data from ICU patients, most common etiology in some of these patients were mainly SIADH, and the SIADH was associated with neurological signs and symptomatology. The mean serum sodium per urea prior to urea therapy was 124.8 MEq per liter. There was indeed a significant increase in serum sodium from the second day of treatment. The mean serum sodium was 131.4 MEq per liter. Serum sodium normalized by day 4. Treatment protocol included water restriction and initial treatment with hypertonic saline. Average urea dose was 45 grams per day. Again, no major side effects of urea were noted, primarily no evidence of osmotic demyelination syndrome were observed with the use of urea. More studies, as you see in this slide, suggest that the use of urea is associated with both efficacy and safety, such as in group 1, in 50 patients with mild hyponatremia with a mean serum sodium of 128 MEqs, the mean urea dose was 46 grams per day, and mean serum sodium increased to 135 MEq per day, despite a fluid intake of more than 2 liters per day. Again, suggesting that there isn't any reason to restrict fluid intake if you're giving urea for hyponatremia. In the second group, there were 35 patients with severe hyponatremia acquired outside of the hospital. The serum sodium was as low as 115 MEq per liter, and the serum sodium increased appropriately. All patients with neurological symptoms made a rapid recovery. More clinical data on urea in patients with SIADH compared to Vaptans, as shown in this slide. A 2-year treatment period treated with Vaptans for 1 year, followed by an 8-day holiday, and then treated for 1 year with urea. Serum sodium measured every 2 monthly, and 13 patients enrolled in the study showed an initial serum sodium of 125 MEq per liter, and the Vaptans increased the sodium to 135, while the treatment was actually stopped and there was a treatment holiday. It recurred in about 12 patients when the Vaptans were terminated. These 12 patients, when they started utilizing the urea, the sodium increased to 135 MEq per liter, again suggesting the efficacy of urea and the safety in terms of well tolerated with the use of urea. So urea in hyponatremia, we have a lot of data so far as shown in patients with SIADH. This is another slide that is telling us about the utilization of urea in acute SIADH patients with subarachnoid hemorrhage. A single center experience, a retrospective analysis study. All patients who had SIADH-induced hyponatremia had a sodium below 130 MEq despite saline administration, or it was associated with clinical deterioration, and hence, when they were treated with urea, it is given about 15 to 30 grams TID or QID for 5 days. The median increase in plasma sodium over the first day was 3 MEq per liter. Hyponatremia was corrected in all patients with median time to sodium more than 130 and more than 135 of 1 and 3 days respectively. Oral urea was well tolerated. In the next slide, we are discussing the new product, and it's called Urena. Urina is the new palatable form of urea. The guideline-directed medical treatment of hyponatremia, as depicted and discussed earlier, is telling us that the urea in a good palatable form may have an impact factor in hyponatremia by correcting it with safety. Indeed, urina is now a medical food made of generally recognized safe by FDA ingredients. It's developed by board-certified nephrologists. The proprietary blend of urea with other safe ingredients to enhance the palatability and tolerability has been discussed. It's well tolerated from gastrointestinal standpoint with no hepatotoxicity or no nephrotoxicity. The 15-gram dose per sachet, this can be taken by dissolving it in 3 to 4 ounces of water or 3 to 4 ounces of juice. Typical dose is about 15 to 60 grams per day. The next slide, urina is the palatable version of urea as shown here in picture form. It has a lemon-lime flavor. 15 grams of urea per single serving sachet is available in 8 sachets per box. Easily mixes with 3 to 4 ounces of water or juice. Cost-effective option. It is indeed a cost-effective option for the treatment of hyponatremia. So in summary, we discussed about the hyponatremia, its etiology, the causes, the euvolemic and the hypervolemic hyponatremia. Some of the clinical trials discussed in terms of mortality and morbidity that is related to hyponatremia. We also discussed the treatment strategies and the lack thereof of an effective strategy from a cost-effective standpoint, as well as from a utilization standpoint, both in inpatient and outpatient setting. We also discussed the new concept of urea, and we talked about the guidelines that is now recommending urea. We talked about the urea and the clinical trials associated with safety and efficacy of urea. And now we discuss the palatable form of urea in the form of urina. We have references for you for your reading pleasure. I thank you for your attention.
Okay.
How did it go?
All right, that was great.
Did you hear me?
Yeah,
My voice?
yeah.
Carried it all the way?
Perfect. Yeah, looks
I
like
think
it.
in between every now and then there are two